at Kaohsiung Veteran General Hospital. And back in March, I and our superintendent visited your hospital, and we accepted a memorandum of understanding for future cooperation in the personnel training, knowledge exchange. And I think today's program is the start of our cooperation. And since I'm a head and neck surgeon, so I proposed an introduction session for how we treat our head and neck cancer patient in our hospital. And I think the oral cancer or other pharynx cancer, I think will be an issue in Vietnam also. So that's why I proposed this program. And I'm also glad to have the nuclear medicine and oncology to give us an introduction. I think this today will be a beginning of our cooperation, and I will wish we have a good program today, and we will broaden our cooperation, and maybe we will arrange future programs according to our mutual interests. So may I ask Dr. Professor Fan to give us a few words? Professor Fan, could you hear our voice? Could you give us some words before we start our program?听不到，对。是我这边是。
看起来没讲话嘞。
没有讲话
Can you hear us?
Yes, very clear.
Oh, yes. Could you give us some words before our next talk?
Yes, Professor Phạm Cẩm Vân will have some words before we start today.
Yes, dear Professor Kang Bon-wan and all colleagues, thank you so much for helping us today. And today we are very honored to join with your expert, especially in the head and leg cancer treatment. And we hope that in the future we will have many collaboration between Vietnam and Taiwan, especially in Bạch Mai Hospital and Kaohsiung Veteran General Hospital. And we hope that in the future we will have many symposium and another conference, and also for the give some advice for us. Thank you so much.
Thank you, Professor. I think both me as the department chair of the head and neck surgery department, I invited our section division director of head and neck surgery, Professor Lee, to give us an introduction about how we treat our patient in head and neck cancer patient in the hospital. Let's welcome Professor Lee.
来看看那个 slide。
那他会看得到。
第一层，第一层。
Hello, Professor Fan. Could you see the slide?
Yes, we can see very clear.
Okay, let's welcome Professor Lee to start his talk.
Today we will report patient-centric approach in head and neck cancer treatment. I'm Tim Shili, the coordinator of head and neck cancer team since 2024. A special thanks to Professor Yao Xiang, Professor Wang Kang to support this team. This is the presentation outline. This is the organization chart of this cancer center and head and neck cancer team. Under the supervision of the director, we have established a cancer quality management committee. The main purpose of this committee is to manage and oversee the quality of cancer treatment at our hospital. Under the committee, there is a cancer center. And the main purpose of the center is to coordinate and oversee various activities. It includes subcommittees for cancer prevention, quality improvement, cancer records review, palliative care, and more. And at the implementation level or execution level, we have multidisciplinary team, clinical care department, clinical prevention department, and various clinical divisions. Additionally, our related treatment department also include the pharmacy department, nursing department, social work unit, and more. Moving on, let's take a look at the operation of head and neck cancer team. First, our weekly activities include case discussion, covering special cases, pre-treatment and post-treatment discussion. Secondarily, we have monthly activities such as education training and indicator reviews. For special cases, we have detailed reports, including the reports on deaths within 30 days of chemotherapy, surgery, or radiotherapy. There are considering 3 reporting events. Each quarter, we will participate in our cancer committee meetings. Annually, activities include guideline revision, producing an annual report, and setting yearly objectives. This diagram illustrates our overall treatment process, which includes patient contact during outpatient department or consultation, followed by scheduled examinations such as ultrasound, endoscope, and biopsies. Subsequently, it also involves imaging tests like head and neck CT, MRI, or PET. Further steps include arranged aspiration, surgery, or related systemic treatment. Our mission is to provide patient-centric, high-quality head and neck cancer treatment. This image illustrates our weekly joint meeting, where the focus is on treatment, pre-treatment, post-treatment, and necessary case discussion. During the discussion, we encourage all members to fully express their opinion, which are compiled into records to serve as references and recommendations for the attending physicians. Allow me to briefly introduce the scoring system we established in 2022 for the treatment therapy. As shown above, we categorize all pathologic features into low, intermediate, high, and very high based on literature review and NCCN guidelines. For example, pathologic T3 or T4 cases is classified as intermediate risk and should at least undergo radiotherapy. In other instances, if a case has more than 2 positive extracapsular brain nodes, it is classified as very high risk and should undergo adjuvant chemoradiotherapy and additional UFR maintenance therapy. This year, for stage 3, we add the case with MTR less than 0.45. This case should undergo chemoradiotherapy. Let's see an example to practice the process of our scoring system. For instance, if a patient has more than 2 extracapsular nodes metastasis, they will fall under a very high-risk category. Therefore, they should undergo chemoradiotherapy and UFR maintenance therapy. If this is not the case, this process will continue to the next step. Suppose there are no high-risk factors and the patient is a pathologic T3 or T4 cases. They would classify as intermediate risk and should undergo radiotherapy. If they have additional minor risk factors, this process will then move forward to further chemoradiotherapy. Let's introduce the process of patient hospitalization surgery. First, this is the pre-op evaluation. On the day of surgery, we will perform the scheduled resection and reconstruction procedure. Afterwards, the patient is transferred to the intensive care unit. Once the condition is stabilized, the patient is moved to a general ward. I will skip this slide. In addition to a aforementioned treatment process, this patient must also adhere to the relevant stance of cancer therapy. This includes ensuring all the assessment aligned with the guideline for oral cancer treatment. Subsequently, a comprehensive treatment must be developed and surgery conducted accordingly. Following our scoring system, the adjuvant chemotherapy is arranged. Let's continue by demonstrating to repel portable events and the outcome of quality improvement in medical records. First, let's introduce the team's medical record quality improvement initiatives. We divide our quality improvement efforts into different parts. For the physicians, we create a relevant template for their use. In the MP or residence in oral surgery department, we emphasize the need to document specific factors in the case records. This includes the birth prognostic risk factors, clinical and pathologic staging, and the requirement to create a new treatment plan when there is a recurrence or a change in treatment strategies. Additionally, the head and neck cancer team require quality improvement due to an excessive number of reportable events. Our reportable events can be categorized into several aspects, with the majority involve the chemotherapy and nutrition. For the chemotherapy aspect, we have established a comprehensive chemotherapy review system and preventive measures for chemotherapy side effects this year. Therefore, our quality improvement focus is on nutrition support. We analyze the weight of patient for each reportable event and discover a very important fact. All patients who experience major events had a weight loss of up to 5%. Therefore, by reviewing the existing guideline, it is noted that the weight loss of 5% in 1 month or more than 10% in 6 months needs nutrition support interventions. Literature also indicates that if there is a dysphagia, a BMI less than 18.5 or weight loss more than 4.5% during treatment, this condition requires proactive nutrition intervention. Consequently, we established a quality control circle to improve the quality of such intervention. We will spend some time to discuss the process of treatment guideline revision. The Gantt chart illustrates the timeline of the revision process. It included the pre-meeting, multiple reports, ENT doctor radiation oncology discussion, and finally approved by the head and neck cancer team. We just show some key points of the revision and take a look at the systemic treatment in non-NPC head and neck cancer. At first, performance status, treatment goal, NGS, and CPS was considered in treatment plan. Second, docetaxel was introduced as a radiosensor in patients with chemoradiotherapy or adjuvant chemoradiotherapy. We reviewed the literature to confirm the rationale for inclusion of docetaxel in chemoradiotherapy. Also, there was some debate in the definition of clear margin. This year, our consensus was to maintain the original definition. We will further discuss this issue next year. I will skip this slide. Finally, the normal points of annual revision was summarized. Nutrition support was stressed. Docetaxel could be used in patients who was intolerant to cisplatin. The escalation and therapy in HPV positive oropharyngeal cancer according to the ECOG 3311 result. And besides the survival rate, quality of life and return to work was also our goals of treatment. Now we will present the typical cases to elaborate our treatment protocol. A 62-year-old male was diagnosed as NPC with DSMS. His EBV DNA titer was more than 143,000. The CPS for PD-L1 was 25. Okay, and then the PET image was skipped. And in the after 6 cycles of pembrolizumab and chemotherapy, a partial response was achieved. In tongue cancer, advanced tongue cancer, we also performed a compartment resection to achieve a safe margin. In this case, the margin was 9 millimeters. A 58-years-old male was with advanced buccal cancer. He underwent bridge chemotherapy and compartment resection later. We used the abrupt resection to achieve clear margin. The pterygoid plate was removed with the tumor, and the margin was adequate. After ablation of tumor, the plastic surgeon performed the reconstruction, and he underwent the chemoradiotherapy according to our scoring system. And next, we will demonstrate some publication by our head and neck cancer team. First is the association between the technical outcome and oral cancer survival. At present, this is the first paper to discuss this concept. The next is the stromal categorization in recurrent oral cancer. The tumor microenvironment was divided into 3 groups. Category 1 is high STS and low TSR. The category 3 is low STS and high TSR. Using the survival decision tree, the patient will group into 3 categories. Patient with prior radiotherapy and stroma category 3 had a worse outcome. The 5-year overall survival was less than 7%. EGFR application is about 15% in P16 negative head and neck cancer. We aim to explore the association between the EGFR and the M2 polarization. This paper was just published in head and neck. We also participate many international symposiums like the IFNOS in Rome, AO in Nashville, Head and Neck Society Conference in Singapore. This year, we also invite Daniel Faden for keynote lecture in our head and neck cancer team. His excellent work in HPV DNA detection in HPV-related oropharyngeal cancer inspires all of us. I would like to finish by restating today's key issue. The involvement of multidisciplinary team in treatment is crucial. The team regularly monitoring the quality of treatment, reports necessary incidents, and improve case documentation. We continuously enhance our team outcomes through training, education, collaboration, and communication. Thank you, everyone.
Thank you, Professor Lee's presentation. I think we maybe make a short discussion about this topic before we go into the next topic. Since to get a timely response from the audience. Professor Pham, do you have any questions or issues from your side of treating? Do you have what's your experience in treating or facing this head and neck cancer patient there?
Thank you so much for your huge achievement. I think that. Yes, and actually in Bạch Hospital, we also have MDT team, but you only do for the liver cancer, for the brain tumor, and for the breast cancer, but for the head and neck cancer, we didn't have MDT. And I found that in your presentation, you also have MDT for head and neck cancer. I think it's very good. And I also listened about your speech about the training and education. You can do it every month. If I have a success, if you have education training in English, please permit us to join so that you can learn more.
Yes, I think there are several doctors from abroad to get trained to participate in our practice for caring this head and neck cancer patients. And the monthly training program is actually for our multiple discipline team. We accept the fellow to come to our hospital to join the head and neck cancer team. If you have appropriate candidate to send them to our hospital, they will be welcome. We are happy to accept fellows. Okay.
Thank you so much. And we actually in Vietnam for the head and neck cancer, we also have some experts of surgeon. And but for the big surgeon, for the complicated patient, it is also difficult for us for the surgery. So that in the future, can we send some patient for operation to your hospital?
I think that yes. Well, we are broadening our approach to the international patients. And if you have the difficult patients, we are they are more than welcome to come here. And of course, we need to evaluate their images before they come to see if the tumor is operable or not.
Okay, thank you so much. So that in the future, if we have head and neck cancer and the patient and your and their family have enough money to go abroad, we will discuss with you so that after discussion, we will send some patient in your hospital. Thank you so much.
Hello. Thank you for your presentation. I'm Dr. Wai Chen. I have a question about adjuvant therapy. I see that in your hospital, you use UFO for very high risk group in stage 3 head and neck cancer. Can you share your experience about using UFO in head and neck cancer?
台湾是就讲一个事情，我直接讲 ，OK。
And thank you for your question. We have reviewed the literature and found that the human chemotherapy and maintenance and UFO maintenance is helpful and beneficial for those patients with high-risk features. So we include UFO maintenance in our very high-risk group.
And I have a supplement. This oral UFO is not is used after regular adjuvant therapy, like we completed this post-operative concurrent chemotherapy. Then we have more prescribed 1 or 2 years oral UFO for maintenance because we have not our hospital, the hospital in Taiwan, and I think 2 institutions showed if in those very high risk group, the oral UFO will reduce the recurrence rate, better tumor control, and that's why we incorporated oral UFO to our very high risk group patient treatment.
Thank you.
Okay.
Thank you. Thank you, Dr. Lee, for the interesting presentation. To know more about the scoring system for adjuvant therapy, you got a scoring system 1, 2, 3 in the low risk group. So can you tell me more about how you calculate this score?
If the patient is grouping with the low risk factors, we will summarize the total score. If the score is 0 to 1, we suggest observation. If the score is 2, we suggest radiotherapy. And if the score is 3 or more, we suggest chemoradiotherapy for patients with multiple low risk factors.
I mean, what factors you consider in calculating this score?
The slide is above was the patient was pathologic N1 disease, pathologic lymphovascular permeation, EOI more than 10 millimeter, and poor differentiation, and margin 3 to 5 millimeter.
刚才那个。Oh yeah, so the maximum score may be 5?
那在上面，
We will show the slide.
上一点，要
Could you see the slide?
Yes. Yes, we can see your slide.
Yes.
Yes, so the low risk factors such as lymphovascular invasion, PNI, or DOI more than 10 millimeter, or poor differentiation, or margin. There's margin, but not enough. We categorize those two low risk factor. But if there are more than two, then we still suggest radiation therapy. If there are three or more, the chemoradiation is also is recommended. So even though the patient did not have the intermediate risk or high risk factors, if they have more than two or three low risk factors, we will have adjuvant therapy for them.
Thank you.
再回到画面，视距。Okay, so I heard that the head and neck cancer still does not have MDT layer, right? So and I think that's we can share our experience if your hospital is wants to accept MDT for head and neck cancer patient. I think it's complicated for our head and neck cancer patient. They are usually low social economics and they need more social or financial support than other cancer patients, and they have more nutritional problem, and so multiple discipline, and they also have the psychosocial problems needs support. So in addition to the traditional medical treatment or diagnosis, we have a supported team for these patients. And we will be glad to share our experiences in establishing this multiple discipline team. So may we go into the second topic, or still have more questions for us?
Yeah, thank you very much. We may give you more questions later when we have. Thank you.
Okay, so I think we should make move on to the second topic. Okay.
Okay, thank you. Now I would like to invite Dr. Đào Mạnh Phương. He will have a speech about the nuclear medicine and oncology center for introduction, and after that we will share a case study and we will discuss with you more. Thank you.
Dear Professor Kang Bo Kwang and Dr. Chin Chia-Lee, today I'm very happy to be here to introduce about our center. I think it's short time, so I may review some main characteristics of our center, and then we will have two case study. Firstly, about our country, Vietnam. You can see it's not so far from the country, only 3 hours flying. And coming to Vietnam, you can enjoy the nature beauty as well as enjoy the private life in the central areas. Yeah. And with my hospital, this is a history and development of our hospital with more than 110 years of developing. Until now, we become the biggest hospital in the north and at the highest level of healthcare system in Vietnam, with about 306,000 beds and around 4,000 staff, including around 940 doctors, more than. Chia sẻ đi, em chia sẻ.
Em đang chia sẻ đấy rồi. Em đang chia sẻ đây rồi. Em không hiểu như gì.
Anh thấy đang cho full slide. Excuse me, can you see the slide? Excuse me, can you see when the slide is moving? Em đọc lại rồi share lại. Excuse me, can you see the slide now?
Yes, we can see your slide.
Okay. I'm sorry for this technical issue. Coming back with our hospital of more than 110 years of developing, now we become the biggest hospital in the north at the highest level of healthcare system in Vietnam. Now we have about 4,000 staff, including 940 doctors, around 210 pharmacists, and more than 1,900 nurses, technicians, and midwives. And these are the number of inpatients and outpatients through the years. You can see in the final year, we have the significant increase in the number of both inpatient and outpatient. And coming with our center, our board of director, we have oncologists, nuclear medicine physician, technologists, engineer and medical physicists, and nurses. And this image of our Professor Phạm Cẩm Phương, director of the center. And the infrastructure, we have 3 outpatient clinics, 1 fourth floor areas, and 2 floors in the new building with areas around 4,000 meters, with equipment for PET-CT, rotating knife, ultrasound, ECG, and gene stem cell units. And this is the image of some equipment at our center from PET-CT, LiDAR, and rotating knife system. In terms of function and duties, we are not only diagnose and treat for our patient, we also perform research and development, education training, and regional and international cooperation, and provide other services. In terms of oncology, we can give the patient chemotherapy, targeted therapy, immunotherapy, and radiotherapy, and radiosurgery. We also perform some minor surgery and provide palliative care and some gene therapy. In terms of nuclear medicine, we also provide both diagnostic and treatment procedures. This is image of our doctor with PET-CT simulation and IMRT radiation therapy in planning in the nuclear medicine and chronic center. The upper left image is image of Dr. Y, who also participated also in the meeting today. And this is our protocol from the technique from preparing the patient, simulation, and give radiation therapy, simulation, and quality control, and finally give treatment for the patient. And this is one case study with lung cancer who refused to perform surgery, and we treat him with concurrent radiation chemotherapy therapy. And after 6 cycles of chemotherapy, the patient gets a complete response with no radiation complication. And this is the image of the rotating camera system at our hospital. Until now, we have been treated for around 7,600 patients. And this is some case study. The first study is with brain metastasis, and after treatment, the patient had a good clinical and complete response. Another case study with brainstem glioma. After 12 months from the time of treatment, the patient got a complete response and improved the symptoms of headache and now no esophageal. In terms of chemotherapy, we can provide many chemo agents such as paclitaxel, docetaxel, cytarabine, and many more. We can also give some targeted therapy for our patients, such as bevacizumab, cetuximab, or subTKI. In terms of immunotherapy, at the moment, there are 3 agents available in Vietnam, including pembrolizumab, atezolizumab, and durvalumab. At our center, we also treated for patients with liver cancer or liver metastasis with selective internal radiation therapy with Y90 microsphere, and this is a protocol, and the results, some trial has been done with good results, and some case study with good response. We also give a patient permanent radioactive iodine seed implant in treating prostate cancer. This is a protocol, and the image of our team who has been done this technique. And one case study with complete response, the tumor disappeared and the patient got normal urinary after treatment. We also have a gene and stem cell unit with not only screening for BRCA1, 2, or some other genes, but for targeted treatment. We also have NGS system and perform tests for other departments, other hospital. And in terms of cell therapy, we also give some treatment in coordination with other departments. And up till now, there are some achievement we have got. In terms of collaboration, we are very happy to have a connection with many universities in Vietnam and in other countries, especially in Taiwan, with Taipei Medical University, Taipei Veteran General Hospital, and you today. With a very brief introduction, I hope that you have some kind of overview about our center. So we know. I think that if we know more about each other, they have more chance for us to, to cooperate with the other in the future. And then now we have 2 clinical case study with head and neck cancer. The first case, 63 years old male with medical history of alcoholism and smoking for many years. In 2022, he has been diagnosed with hypopharyngeal cancer with cervical lymph node metastasis. The stage were T2 and 2M0, and he has been treated with concurrent chemoradiotherapy with partial response and remaining small cervical lymph nodes after treatment. Then the patient received capecitabine maintenance treatment. But to 2023, the lymph nodes rapidly increase in size and become uncertained and painful. So he admitted to our center to be treated. This is my at this moment with a PN1 and large mass in left neck area, bleeding and pain in many areas of neck with VAS score of 7, limited neck turning and poor eating. This is a CT image of the tumor with the left cervical area has an organized mass measuring around 7 and 6 centimeters, invading the carotid space and the left pharyngeal space, and unclear boundary with the left parotid gland, extensive skin invasion, and subcutaneous tissue causing extension, ulceration. After we have a tumor board, and after the meeting, we decided to give him the treatment with pembrolizumab with CF. After one cycle of CF plus pembrolizumab, we can see the patient have the pain become less, and he can eat and drink normally, and he can move his neck. And after 3 weeks, you can see the tumor decrease significantly in size. And after 3 cycle and 6 cycle, you can see the responding very good. And now, after 6 cycles of treatment, the tumor decrease in size around more than a half. And now we are going to the second case story, and now we still check for him, and we also want to hear the suggestion from you. What should do next in this case? Another case is 68-year-old male with symptoms of tongue pain, persistent ulceration of the left end of the tongue, but medical treatment did not help. The patient went to another oncology hospital and had a biopsy result of squamous cell carcinoma. And then he was referred to our hospital with the diagnosis of T3 and 0M0 lung cancer with stage 2 chronic kidney disease. He has been treated with radiation therapy with now 66 rate, and to June 2023, this is my at the time of diagnosis. We can see the nodal lesion on the left anterior border of the tongue, around about 1 and 2 centimeters in size, increased signal on steer, strong enhancement after injection, and limited assessment of invasion. Until August 2023, 1 month after radiotherapy, the lesion decreased in size compared to the old film. Difficult to detect on the pre-injection film. The boundaries were less clear after injection. And until October 2023, the infiltrative lesion area slightly increased signal on steer, but unclear edge and boundary, but reduced in size compared to the previous films, and has poor enhancements. Until December 2023, lesions tend to recur and increase in size compared to the first film. So This is the damage 2 times. So now the patient come back with a lot of tongue pain and tongue ulcers, poorly eat and lose 6 kilograms per month with stage 2 chronic kidney disease. So we really want to hear from you. What is the next treatment option? Thank you very much for your attention.
Thank you for your excellent presentation. So this is a very challenging and tough cases, and I will suggest, and we may suggest some recommendation. Doctors, do you have any opinion for these cases? Next one. 这最后一个。
是多少钱？知道钱吗？
没关系，手在那边。
Could you show the next slide? So this is tongue cancer treated with the radiotherapy and then return.
Professor,
It is the first slide.
Yeah, so this is the picture of, this is before irradiation. So is there any image about the current state? Because we have 3 major weapons to treat the cancer. It's surgery, irradiation, and chemotherapy. So we need to evaluate what is the best practice for the patient in such a recurrent state. Do you think it is possible to have the resection of the tumor?
In this patient, at the time of diagnosis, the patient didn't agree surgery, and he have a chronic renal disease, so we can't use chemotherapy for him. But at this time the disease recurs. If the patient agrees surgery, can you have a surgery for him? And if he turn one surgery surgery is not possible, can you have as an option for him?
So if the resection is not indicated in current state, so what about the NGS data or other possible choice for chemotherapy or immunotherapy or target therapy?
Because he have a chronic renal disease, so can we use chemotherapy for stage 2 chronic renal disease chemotherapy?
So from your information, the patient has some problem with kidney function. But usually in our head and neck cancer, it is always use the cisplatin family. For those who have impaired renal function, carboplatin may be the one of the choice. Usually the fluorouracil is another regimen. But nowadays in Taiwan, from the FDA approval, we use immunotherapy for some patients that is indicated. That means if he has some expression of the PD-L1, then we may use the nivolumab or pembrolizumab. I know that in Vietnam, these two drugs are also option. So I wonder if the patient have such information or his T2 special stat.
Do you have PD-L1 test?
Yes, we have a PD-L1 test, and we also note for the CPS score for the head and neck cancer.
So the result for this patient is about the number of CPS is
About this patient, it is for the CPS, this score is 20.
20, great, we got it. Another issue is, do you have PET examination for this patient to exclude the distant metastasis?
Yes,
do you have PET?
in Vietnam we also have a PET CT, and we can do PET CT for this patient. And this patient didn't have any metastasis.
Okay, so we will, if the patient didn't have distant metastasis, we will move to the next step to check whether the patient could be treated by the surgery or the chemoradiotherapy. In this case, he just underwent the radiotherapy, so it may the tumor might be resistant to radiotherapy. So next step could be several choice. Could it be ablation with the surgery? Or do you have the staff or doctors to excision the tumor? Do you have head and neck surgeon or general surgeon to remove the tumor?
Yes, at our hospital, we have a department for head and neck surgery, but the patient refused to perform surgery.
Okay, so if the surgery or local treatment is unfit for this patient, then we will move to systemic treatment for this patient. So according to the keynote 48, we will suggest to, you have the PD-L1 data is about 20, more than 20. So if the patient, the patient could be divided to check the patient is high tumor burden or low tumor burden. If the patient is high tumor burden and the PD-L1 is 20, we will suggest you use the pembrolizumab with the chemotherapy. This is, I think, is Dr. Su and our suggestion. The first step is the suggestion is like this one. Do you agree?
Yes, we are very agree with this. The only problem is TMB test is not available in Vietnam, so we may use PD-L1 test score as a kind of indicator.
You use the PD-L1 enough. PD-L1 alone is enough. You say I didn't have the TMB.
TMB test is not available in Vietnam at the moment.
Okay, but I think that we saw that PD-L1 is enough, good, and is enough for us to choose the suggestion. So my recommendation is that the first is the pembrolizumab with the chemotherapy. And then the next step, you can also try the salvage chemotherapy. Like if the docetaxel is not included in your treatment, you could suggest to use the taxane like the docetaxel or paclitaxel with the chemotherapy. If the patient could not afford the pembrolizumab.
Yes, yeah.
So we like to use the salvage chemotherapy like immunochemotherapy, like the pembro plus chemotherapy, or the chemotherapy with the double regimen like the docetaxel plus cisplatin or carboplatin.
Yeah.
And if the patient is high tumor burden, atezolizumab with the chemotherapy could be considered.
Yes.
So
in this case, immunotherapy plus chemotherapy is the first option. The second option, if the patient cannot afford for pembrolizumab, is chemotherapy alone with first line taxane, right?
Yeah.
Yeah. Thank you very much.
Okay. And then the next is the discussion and Q&A. Do you have any further question for the head and neck cancer team or the treatment for head and neck cancer?
Yeah, this is only the first meeting, so I hope we have more chance to know more about each other. You said that you have a kind of annually or monthly meeting, so may our doctors can join and learn how you host this program and learn knowledge from this schedule?
Yes, we asked and invited all the head and neck surgeons to participate in the head and neck cancer team, and we have weekly joint meeting every weekly. We will discuss the pre-treatment cases to confirm the image or special issues. And then we will also discuss the post-treatment pathological features to discuss with the radiation oncologist to discuss whether the patient is grouped to the very high risk, or the low risk. So we perform the joint meeting weekly, and then we will report the report. We also have a monthly training program and education, and then we will have annually guideline revision and the annual report.
Yeah, thank you very much. Actually, I have a very good time in Taipei in the Veterans General Hospital system because I used to have a short time at Taipei Veterans General Hospital. So now, from this time, I learned many valuable knowledge as well as experience. So I hope that we will more chances for our doctor to come to the country to learn more and know more about the the team. So in the case you have a kind of fellowship, observation scholarship, please let us know. Thank you very much.
Sure, we have we will provide the application for the observation fellowship for head and neck cancer and sleep medicine in our hospital. So you are encouraged to participate and apply for this program.
Yeah, thank you very much. So I may take the contact address after the meeting, or may through the hospital office member staff. Thank you very much for the sharing today.
Thank you everyone.
Thank you. Bye bye. See you soon.
Bye. Bye. Okay.